Yeah, thank you, Suvan. Great being back on this course. This is it's a very popular course in the AIOS for many years now. And SICS, considering iris expansion, pupil expansion devices are not required, I don't believe in that. I always feel that the pupil should be large enough to do a good SICS. So if the pupil is small, do not hesitate in putting iris retractor hooks. At any stage of the case also you can put iris retractor hooks. So it is not a question that you cannot put it after trying to prolapse or whatever. So I'll be showing you in different scenarios where you can use iris retractor. So the ring possibly is not possible. Iris retractor hooks are to be used, and how they can be used. You just saw one iris retractor hook being used. There are different companies which make iris hooks. There are very thin ones which go in through even 0.25 millimeter openings. So identify those. I don't have any financial interest in that, but the Alcon ones and the Orolab hooks which they make are very small, so that you don't have to make more than 0.25 incision for this. And the incisions have to be stab incisions at the limbus. So it should not go through the cornea and then enter, because it has to be in the plane of the iris, and it has to retract the iris in that plane itself. Otherwise, if you go through the cornea, it will retract the iris up and the anterior chamber will be crowded. Here there is a added problem that you need more anterior chamber in SICS, because you need to have space in the anterior chamber to get the nucleus out into the anterior chamber. And also the incision, when you make an incision, at least 6 to 7 millimeter incision, then these nuclei has to come out through that. And the iris, if you put iris retractor hooks on the sides of your incision, it usually lifts up the iris a little bit. Then your manipulation of instruments going through the incision will again damage the iris which has been retracted up. So to make the problem in SICS is there are two. One is you need to have a very large rhexis. Second, you need to bring the nucleus into the anterior chamber. Phaco you don't have to bring. You need to have just the pupil size rhexis. So you can just make it 5 millimeters and then do it in the bag. Oh, finally, half of the thing was shown without this. And the other problem is that we have to bring out a nucleus. Bringing out a nucleus needs a larger rhexis, especially if you are more than grade 3 nucleus. So the nucleus size decides the size of your rhexis in an SICS. Not like in a phaco when you have a set nucleus size, pupil rhexis size in this. No financial interest in this talk. Problem I told you, large rhexis and the nucleus. See, if you have a small rhexis, pupil, you tend to make a smaller rhexis, and you do forcible hydrodissection, and you see the pupil snap now. The pupil just now snapped, because the fluid goes behind with a smaller rhexis, the nucleus lifts up, fluid collects behind and snaps open. It blocks the rhexis. So we will tend to create a smaller rhexis when you have a smaller thing. So here, in an SICS, you can sometimes get away with in rigid pupils, you can get away with stretching. Some are fibrotic pupils which you will get small time sphincter tears when you do this. Not in very elastic ones. Elastic ones you do this, it will come back to the normal size or even become smaller. So here the tightness of the pupil is also gone. And also it will give small sphincter tears, and with this you can even make 5.5 pupil, and the nucleus, even if it is so large, it can come out through the pupil because it is stretchable now and the rigidity is gone. In a moderate pupil, so if you do not want to use that, but you need to do a larger rhexis, you have to do it under your iris. So again, this needs a lot of practice, but even if with practice, you should look at the flap which is going under the rhexis. So 2 strokes away from the center, 2 strokes towards the center. Then it can retain the rhexis margin somewhere under the iris. It's all a blind thing, but then it won't go to the periphery. So if you notice, 2 strokes are away from the center of the pupil, 2 strokes are within towards the center. Then you can make it large enough, but still, I don't know what is the size of the nucleus, this capsular rhexis. So the nucleus may not come out that very easily. So I would not want to do all these blind procedures in SICS. So this is the very small pupil. So this is my point. Creating an incision which is sub-incisional, that is through the floor of the SICS tunnel, and that will retract the iris at the incision. And now you have the 5 millimeter is not enough. You will have to retract it more. Sphincter may tear, but you have to get this nucleus out. This is a large nucleus, and I'm doing a 6.5 to maybe 7 millimeter rexus, because these kind of capsules do not stretch that very well, because they are fibrotic ones, they are mature cataracts. So then I get the space to get out this nucleus. One pole comes out. You can do whichever way, from the left or right or clockwise or anti-clockwise. But the problem here is that the space within the bag, within the anterior chamber might be less, and so you may not be able to bring the nucleus fully out. But if more than 180 degree of the nucleus rotates, that means that it is very, very loose inside the bag. Only the temporal, I am doing it temporal, so only the temporal half needs to be out into the anterior chamber. Once you get the vectis outside, you can dodge it left to right and get the whole nucleus out, and then get the nucleus out. So here, the nucleus comes out very safely with all the hooks on. But later on, we can even see this is a very hard kind of nucleus. So here I would definitely want to have a very large rexus so that the nucleus comes out very safely. So here again, staining is very important, although you don't see the stain very much because it is very brown black, but still, as Sudeep was telling in last session, you can't see the sun. So this is called if you get Argentinian flag sign, it is called Botswana flag sign. Because Botswana flag is this black, blue, black, so blue, black, blue. And then now I do a full rexus, and then I take out the subincisional one. So already it has been stressed and it is loose there, and your manipulation and taking out the nucleus and all will be little more easy when you have the hook away from your tunnel. Some people feel very uncomfortable having the hook under the tunnel while doing this maneuver. While this is being done, the part close to your incision is widely open, and so as you see 180 degree has been rotated. So it is sure that the lens is very mobile, and one part is out, and you can lift the other part very gently and bring it into the tunnel, and from there very carefully depress and inject and bring out this huge black kind of nucleus. So here the question is retaining the bag. All the rest are secondary. And then I'm putting the hook back in, because if you have the iris like that, you don't see the rexus margin. I have to see the rexus margin to get out all these cortex. These cortex, you may think that it is easy to take, but they are chunks of cortex which may sit in the periphery, and you will never see them. And later on, they will hydrate and come down into the anterior chamber. So again, the dilated pupil is very necessary to see and identify the hooks in the cortex in the periphery and take out. This is the last one. This is slightly hypermature kind of thing, so not a very huge nucleus. So you can put 3-4 hooks. You can even put 5, so that the tear in between the hooks are lesser. The more hooks you put, the tear between the hooks are lesser, the pupillary margin. So I make a adequate large rexus. Adequate rexus is at least 6 millimeters. Don't compromise on the rexus margin. Otherwise, you will do an ICC. You want to retain the bag, have a larger rexus. So now I release these hooks, 3 hooks. But after I release, I retain them inside, because I know that the pupil will become smaller and I would need them later on to aspirate the cortex. So you can release them and retain them inside the chamber itself. And because they have been stretched and the rigidity is lost, we can always rotate the nucleus out, because the pupil is partially held and the rest has been stretched. So all 3 ways you can try. One is retaining all the hooks, one is removing from the subincisional part, and one is dislodging 3. And then retaining it out. But still, every case of small pupil with the hard nucleus, I will definitely do with iris retractor hooks and the pupil dilated very well, so that I visualize the rexus margin, that it is a large rexus, and I do not hook the bag also out. See, under the iris, if you hook out the nucleus, sometimes you will hook out the whole bag also. You may go underneath the iris, but you will be over the capsule. So for me, when I do SICS mostly in these kind of bad ones, because phaco happens more often nowadays. But when I do this, I want to make sure that my rexus is large and I do not do an ICC inadvertently. Thank you very much.
Thank you, Minu. Wonderful take-home messages. Use a device, large rexus.